Preoperative pulmonary edema can be defined as an abnormal accumulation. It is not just the accumulation of extravascular fluid in the lung parenchyma. It is abnormal. It should not. It is not a normal thing that happens. Normally, there will be space and alveoli. But it is abnormal accumulation. There are two types mainly: cardiogenic and non-cardiogenic. This picture should give you all a very clear idea. So this is a normal lung. This is the alveoli. You have the interstitial space which has a normal negative pressure. This is the capillary vessel, and it has got the both the hydrostatic as well as oncotic pressure. And the type 2 pneumocytes are here. And normally the fluid is drawn from the capillary into the interstitial space, and that gets drained by the lymphatic drainage. So this picture shows you how the fluid is not allowed to enter the alveolar sac or the alveolar space, and it is normally drained into that. Now coming to two types of pulmonary edema, the non-cardiogenic and cardiogenic. In cardiogenic, what happens? Pressure is more than the oncotic pressure. So what happens? The fluid goes into the interstitial space, and the volume that is going is much beyond how the lymphatic can drain it. So the excess fluid goes into the alveoli and causes the fluid accumulation in that, which inhibits or interferes with the gas exchange. Whereas in the other type, you can see the vessels are normal. Here, because it is a cardiogenic, the vessels are dilated, vessels are enlarged, and hydrostatic pressure is more. Whereas in the non-cardiogenic pulmonary edema, the vessel vascular dimensions or the size is normal, but it is the damage to the epithelium, both in the vessel as well as in the alveolar. So the endothelium of the capillaries as well as the epithelium of the alveoli are. So the pressures are normal. The fluid is easily, because it's constantly pushed out from the vessel into the interstitial space. Again, it directly goes in through the leakages, even though the pressure is not very high here. It passes through the gaps in the epithelium into the alveoli. Immediately, as soon as this fluid goes there, neutrophils are recruited. They come here and then release more cytokines, cause more damage, and it becomes a vicious cycle. So that is how the major difference between the cardiogenic and non-cardiogenic pulmonary edema happens. So cardiogenic pulmonary edema or volume overload pulmonary edema is a rapid elevation in hydrostatic pressure in the pulmonary capillaries. This occurs in diseases involving left ventricular systole or diastole, like acute myocarditis, cardiomyopathies, or acute MI, or MSMAI and aortic valve problems, or rhythm failures like atrial fibrillation with rapid ventricular response, ventricular tachycardia, and all these other conditions. Whereas non-cardiogenic pulmonary edema is mainly because of the lung injury, the resultant increase in pulmonary vasculature leakage, leading to movement of fluid rich in proteins into the alveoli and interstitial compartment. Now, the common causes are acute respiratory distress syndrome caused by lung like pneumonia, inhalation injury, or sepsis, pancreatitis, trauma, etc. Now, the pathophysiology, what I showed you, pathology increases extravascular fluid in the lung, is both common to both cardiogenic and non-cardiogenic edema. Fluid comes into the alveoli. The underlying mechanism differs. This already I have shown in the picture, so I will not this sequence occurs. Now, apart from these two types, there is a third condition called neurogenic pulmonary edema. This type of pulmonary edema is attributed to a mainly autonomic nervous system disorder, resulting in exaggerated sympathetic discharge, raising the pulmonary capillary pressure, and extravasation of fluid into the pulmonary. This condition is responsible for pathological entity, the following pathological conditions. One is postoperative hyponatremic encephalopathy, or traumatic brain injury or pheochromocytoma, air embolism, fluid overload, all these things, overzealous fluid administration in certain. So these three are the conditions for neurogenic edema. Fluid overload is the next condition, which is the cause for pulmonary edema. So overzealous fluid administration in some cases of sepsis, excessive intraoperative hemorrhage, that is massive postpartum hemorrhages where you want to restore the volume, you give too much of crystalloid, that results in fluid overload, resuscitation during trauma. All these things can lead to again pulmonary edema. This is a iatrogenic condition. Then it can also happen secondary to renal failure, acute renal failure. So if the patient already has gone into hypovolemia and has gone into renal shutdown to restore the volume, and on top of that, if you give too much of fluid, then it will land up in fluid overload pulmonary edema. Then the another condition is anaphylaxis causing pulmonary edema. Again, the fluid accumulating in the pulmonary tissues because of the allergic reaction. And it commonly implicated agents, just now we saw antibiotic, anesthetic agents, analgesic, etc. And last condition, which can be either pulmonary in origin or non-pulmonary in origin. Non-pulmonary origins are sepsis, trauma, burn, blood transfusion, aspiration, or direct injury to the lung by aspiration, chemical inhalation and all, and vascular injury in the pulmonary tissue resulting in this. Then there is a last condition called negative pressure pulmonary edema. This is mainly occurs during the post-extubation laryngospasm condition, and it is also can occur in patients with sleep apnea, more common in children. Laryngospasm is more common in children, but sometimes post-viral adult patients coming for surgery, they can also exhibit laryngospasm, which can be quite severe. And sleep apnea or biting the endotracheal tube in an intubated patient, tube or epiglottitis in children are all conditions where negative pressure pulmonary edema can happen. Cardiogenic and non-cardiogenic, we have to remember the neurogenic pulmonary edema, fluid overload pulmonary edema, anaphylaxis pulmonary edema, acute injury pulmonary edema, negative pressure pulmonary edema. 5 types we have to remember. And the clinical picture and diagnosis of pulmonary edema can be more or less the same picture will be seen. Whatever be the underlying cause, the picture will be similar. Patient, if he is conscious, will have dyspnea, desaturation, extensive crepitation, spring sputum are present. And diagnosis based on the clinical signs, X-ray test will relieve bilateral infiltrates. You can see florid, fluffy appearance on both sides of the lung. And the management is treat the underlying cause first, then cardiogenic pulmonary edema, response to therapy directed towards the cardiac event, and fluid overload response to fluid restriction and diuretic therapy, and response to steroids and beta agonists, and non-invasive ventilation should be instituted immediately to correct the desaturation and replace traditional invasive intubation. But if hypoxemia becomes very severe, brachial intubation and IPPV with PEEP is indicated. So these are all the treatment modalities that are available, but the treatment of the underlying cause is the main point in the management that we have to remember. Okay. So this is a short form of writing the answer on pulmonary edema. Okay.